Take 5 seconds to read the question and then we'll go through the answer. Okay, so we have a 38-year-old male, history of hypertension, asthma, and a recent diagnosis of pre-excitation cardiac conduction abnormalities. So right off the bat, I mean, how often do you see that mentioned in a question? You'll see questions where a patient has a history of hypertension or asthma, but when you see something like this, that's kind of like, oh, I don't really see that in very many questions. That's usually a moment to pause and just note this, right? That's very important. Now, this patient's presenting to their primary care physician for a fixed erythematous rash over the malar eminences with sparing of the nasolabial folds. So the rash started after a long afternoon at the beach. Okay, so this is kind of telling you that the patient probably had suntan exposure, maybe a water organism if this was like an infectious disease question, but most likely sun exposure because there's a rash. Denies any itching or drainage from the lesion. Also feels a dull soreness in the deltoid region bilaterally. So kind of an interesting combination of findings here. On physical exam, multiple painless ulcers are noted in the oral mucosa. Okay, after a thorough review of the patient's medications, a lab workup is performed and shown below. So let's just quickly go through this. It really helps if you kind of know some of these reference ranges. You can always pull up the reference range sheet on the side here, but borderline high leukocyte count, hemoglobin borderline low. These are actually okay. I wouldn't be overly concerned about these. Let's see if anything sticks out though. So far I'm just scanning this. The creatinine is definitely elevated here. Now there's no mention of kidney disease in this patient, which is interesting. So this is something to kind of note here. So we have an elevation in this creatinine. An ANA antibody is positive. Okay, so now we're thinking rheumatologic, and double-stranded DNA is negative. This would definitely call my attention to lupus had it been positive, but what's really interesting here is the antihistone antibody is positive. So here we have negative, but the antihistone antibody is positive. So I'm putting together my big pieces of the puzzle here. Now, which of the following changes to the electrical conductivity is most likely occurring in ventricular cardiomyocytes as a result of iatrogenic causes in this patient? Now, iatrogenic, again, this is something that we did to cause changes in this patient, and this kind of makes sense. I see this antihistone antibody. Remember, this is associated with, what do we talk about? This is associated classically with drug-induced lupus, right? Drug-induced lupus is where we're going to see these positive antihistone antibodies. So this patient has this history of pre-excitation cardiac conduction abnormalities. Now that might be talking about something like Wolff-Parkinson-White, which is where we get that classic delta wave phenomena. And actually procainamide, right, is a drug that could have been used potentially to treat this patient that has Wolff-Parkinson-White. Now, you don't have to completely know that, but what you should know is there's 3 major things that will give you antihistone antibody positive. Those are isoniazid, right? That's number 1. And then I told you procainamide and hydralazine. So if you put the pieces together here, it doesn't sound like there's anything to do with tuberculosis, so I probably wouldn't be looking at isoniazid, right, in the setting of this antihistone antibody positive. Patient does have hypertension, doesn't mention the vitals, but we're talking about electrical conductivity changes in ventricular cardiomyocytes. Based on that right there, I'm probably not relying here on this hydralazine. I think probably we're talking about something that has to do with the electrical conductivity of the heart, in which procainamide has a direct effect. Now, if I gave a patient procainamide, what kind of effect would I expect to see? Now, what class is this, right? This is going to be a class 1A. Remember, draw out your diagram, right? So here's 1A, here's 1B, and here's my 1C. Okay, now 1A is right in the middle, right? So this is kind of like my classic sodium channel inhibitor of a ventricular action potential. So I would expect to see, right, if this was my normal, right, I would expect to see something like this, a delayed slope. And if I want to go for bonus points here, right, if I want to go for bonus points, remember, it also can delay these potassium channels a little bit. It can push this out by blocking some of the potassium channels. That's why it can delay the QT interval, right? Or it can prolong the QT interval, I should say. It can delay the action potential, okay, because you have a longer distance here. So you can kind of see, I think I gave it away by saying that, there's an increased action potential duration when the patient receives procainamide. In the setting of this drug-induced lupus, right, this is most likely the drug that was given. That's a class 1A antiarrhythmic that would actually increase the action potential duration. Let's just go through some of these other options really quickly here. So what about increased potassium conductance? So what would increase the conductance of potassium? Well, one thing that would do that, and I didn't talk too much about this, is actually adenosine. So adenosine can increase potassium conductance, but remember, class 1A antiarrhythmics actually will inhibit the potassium conductance, and that will cause this to kind of move out a little bit further. This repolarization will move out a little bit further and have a more delayed slope here, causing prolongation in the QT. So this would be the opposite effect of a class 1 antiarrhythmic. What about a decreased action potential duration? Well, we have an increased in this case. If it was a decreased action potential duration, we might be thinking of something more like a 1B antiarrhythmic, like a lidocaine, for example. D, increased vagal nerve output to the atrioventricular node. That's very classic for digoxin, but it's not something that's observed in the setting of the use of procainamide or any of these medications really that are very classic for drug-induced lupus. Inhibition of L-type calcium channel conductance. So again, this would be very classic for, if it was direct inhibition, it might be calcium channel blocker. If it was indirect inhibition, we could be talking about beta blockers, potentially even adenosine, right? But this is not very classic for a 1A antiarrhythmic, which is blocking the fast sodium channels and some of the potassium channels that are responsible for repolarization. So again, this is kind of a harder one, but when you see really strange kind of abnormal things like, history of pre-excitation, conduction abnormalities, this creatinine elevation is probably because the patient has lupus, right? Drug-induced lupus, lupus nephritis, right? You can have effects at the kidney. And then this really calls, if you just have a positive ANA, that tells you something is going on, doesn't quite tell you what. But then you have this positive antihistone antibody that's pretty specific for drug-induced lupus. You go to your 3 drugs, pick the one that is relevant, and then you find out what class it is and connect that with what's going on in this patient. So like I said, harder question, but a few different steps, and it's really good to practice these kind of questions because it really takes you through the process.